The neurologic examination in PACES has hard signs that are easy to pick up if you use the proper technique. They are sensitive and specific and will give you a firm diagnosis. The technique is nuanced and you must do it right to be sure of the signs. We will now demonstrate the upper limb examination.
Thank you for letting me examine you today, sir.
As you approach the patient, be sure to ask the patient to expose himself. In the upper limb examination, the minimum exposure is that the patient should roll up all the sleeves as well as the pants. Ideally, you would ask the patient to take out his shirt. This is especially so for young patients who may have facioscapulohumeral dystrophy and you want to see the overriding scapula. Inspect for fasciculations, but do not flick. Flicking does not add value to the examination.
Alright. Could you hold your hands up like that and close your eyes? Okay, good. Open your eyes. Hold your hands out like that. Make a fist and open quickly.
In addition to the screening test for pronator drift, it is useful to do this additional step, which is to ask the patient to stretch out his hands with wrists cocked up, make a fist, and to ask him to open it quickly. This will easily allow you to identify the presence of a wrist drop, the presence of a grip myotonia, or the presence of bradykinesia, which will give you an idea of the presence of a myotonic dystrophy or Parkinsonism that you can identify easily on the screening.
Okay, so now I'm going to check how relaxed you are. Let me know if there's any pain.
Okay. In the examination for tone, you need to ensure that the patient is relaxed by giving him appropriate instructions. Examine for tone over one joint at a time. Use both slow and fast movements so as to be able to distinguish a dystonia from spasticity. Spasticity is velocity dependent, while dystonia is velocity independent. What not to do is to examine for tone in this manner. So I'm just going to see how relaxed you are. Okay, this is examining over multiple joints at the same time. This does not add value. What you want to do is to catch the spastic flexors. So in the upper limb, the flexors, in this case, for instance, you would do this as the rapid movement and then a slow movement. Okay. Over here, you want to catch the spastic flexors. So first slow to pick up dystonia and then fast to pick up spasticity.
Alright, I'm going to check your reflexes now. So position you nicely.
In the reflex examination, ensure that both hands are positioned symmetrically, alternate testing the right and the left hands. For the triceps reflex, support the patient's hand as you do not want there to be muscle tone while you are testing the reflexes.
Alright, I'm going to check how strong you are now. Could you follow my actions? Don't let me push you down, okay?
Again, position the patient appropriately. Ensure that you test the patient that is not in a position of mechanical disadvantage. So for instance, doing this, so let me see how strong you are, would be testing the patient at a position of mechanical disadvantage and may give you an inaccurate power sign.
Just like here. Wait. So, press that. Push up. Push down. Okay, don't let me uncurl your fingers. And stretch your fingers up.
It is important to compare like for like. So for instance, in this case, you want to compare the power of the patient's finger abduction with that of your own finger abduction. So for instance, you would not want to do this. So let me open your hands. You will not want to do this, which is comparing the power of your finger flexion against the finger abduction. And that would not be a fair comparison. It may lead to an inaccurate finding. At this stage, you will need to decide if additional tests for the power of the median, ulnar, and radial nerves need to be conducted. And so if you notice, for instance, the presence of a benediction sign when you try to do the screening test, or you note the presence of a wrist drop, then you will have to do additional tests to identify the presence of a median, ulnar, or radial neuropathy at this stage.
I'm going to check your sensation now. This is the sharp end of a stick. I'll be using your forehead as a reference point. Can you feel this?
Yep.
Alright, so now I need to close your eyes and tell me whether the sensation in your hands feels the same or whether it's reduced.
Okay.
Close your eyes.
Testing for sensory findings requires the patient to cooperate with you and inform you if there is any difference in the sensory finding. Make sure that you tell the patient that you want to see not just whether the sensation can be felt, but whether it is sharp and it is the same as the forehead. Additionally, please compare the reference point as the forehead of the patient and do not use the sternum when you are testing the upper limbs, because this is because the sternum has a lower reference value of T4 as compared to your upper limbs, which are C5 to T1.
Yep, sharp. 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 Sharp.
Alright, thank you.
You may use either a stick or a neural tip in the cases examination. If you are using a stick, an ideal stick will be a slightly longer stick such as this one and not just a short toothpick. When using a stick, it is important to have consistent pressure applied at each sensory touch point. The way to do this is to grasp the stick very lightly in your fingers, place it on the patient, and slide downwards without applying force. Once again, grasp the sides of the stick slightly just to support it, use the stick's own weight, and slide your hand fingers down. This will ensure that the pressure that you apply is consistent. What you do not want to do is to press this hard into the patient, as that is both painful and your force will vary, and the patient will tell you that one side may feel better, stronger than the other side due to the differing force. If you are using a neural tip, be careful not to use too much force, which can cause injury to the patient. Additionally, for sanitary reasons, if you are using a neural tip, do not test the neural tip on your own fingers before using it on the patient.
I'm going to check how well you can feel vibration sense. So again, I'll be using your forehead as a reference point.
Yep.
Can you feel that? Okay, good. Now close your eyes and tell me whether when you feel the vibration sense stop.
Okay. Yep, it's vibrating. Yeah, and stop. Yep, it's vibrating. Yep, stop.
You may do either vibration sense or proprioception. It is not necessary to do both, as they are both carried by the dorsal column medial lemniscus. When you're doing vibration sense, ensure that you use the right tuning fork, a 128 Hz tuning fork, and not a 512 Hz tuning fork, which we use for hearing. When placing the vibrating tuning fork on the patient, you will need to choose a bony prominence, such as the back of the interphalangeal joint of the thumb or the metacarpal phalangeal joint, and support the finger underneath if possible. There are two accepted ways of doing this. One is to leave it for at least 6 to 8 seconds and ensure that the patient is still able to feel the vibration at the end of 6 to 8 seconds. Or secondly, is to stop the vibration and ask the patient if you can still feel it.
I'm going to check how well you can feel position sense now. Okay, so this would be up, this would be down. I want you to close your eyes and tell me the position, whether it's up or down.
Okay.
Okay, so close your eyes now.
Up. Down. Up.
The other hand.
Down. Up. Up.
Okay, great.
When doing joint position sense, ensure that your movements are not too large. Our proprioception's ability is actually very sensitive, and what you do not want to do is to do motion that is too large, such as this. Sir, is this up or down?
Up.
Up or down?
Down.
Up or down?
Up.
Up or down?
Down.
Okay. This would be excessive motions, and patients with some sensory deficit but not complete loss of the dorsal column, the medial lemniscus function, may be able to give you the correct answer to joint proprioception sense. So you want to use a fine movement, maybe about 5 or 10 degrees deflection. So up or down?
Up.
Up or down?
Down.
Up or down?
Up.
Up or down?
Down.
Alright? And this will give you increased sensitivity of this examination. Additionally, it is important to grasp the fingers from the sides and not top and bottom. Grasp it from the sides. As if you grasp it from top and bottom, the pressure that you apply when deflecting the finger may be sensed by the patient, and that will give you a false positive correct answer in your proprioception test. If you find that there is a deficiency in proprioception or vibration sense at the most distal joint, then the next step to do will be to move upwards and test the next bony prominence in the case of vibration sense, or the next joint in the case of proprioception.
Okay, so now I'll check how well you can coordinate.
Okay.
So just follow me. Put your finger to your nose.
Mm-hmm.
Then your fingertip touch my fingertip.
Yep.
Then go back and forth,
Mhm.
fast as you can. And change hands.
Mm-hmm.
Okay, great. Now follow my actions again.
Mm-hmm.
And flip as fast as you can.
Yeah.
And change that.
Mm-hmm.
Same thing.
Yeah.
The finger nose test should only be done if power is at least 3. Attempting to do the finger nose test with a power of 1 or 2 shows that you do not understand finger nose testing. When doing the finger nose test for dysmetria, ask the patient to lift up his hand, touch his nose, and stretch out all the way to touch your finger. If you hold your finger too close to the patient, such as this, you reduce the sensitivity of your test. Additionally, change the position of your finger from time to time. And the other side, please, sir.
Mm-hmm.
Alright. Okay. Testing for this Diadococinesia, sir, do this for me.
Mm-hmm.
Okay. It's important to get the patient to lift up completely from his other palm.
Mm-hmm.
Sir, lift up completely and do this.
Yep.
Okay. Some patients will not lift up completely and will attempt to do this, and this is actually a compensation for cerebellar dysfunction. So you want them to lift up completely, and when you stress them, what they might do is they might do double motions, or they might do this, which you will identify as this Diadococinesia. We have now completed the upper limb examination. What you need to do next is to do additional tests to localize the findings if necessary. For instance, if you find proximal upper limb weakness with normal sensation and lower motor neuron signs, the next logical step to do is to test for fatigability. Another example, if you find hemiplegia or hemiparesis, the next logical step is to examine the cranial nerves of the patient to localize the lesion. Thank you very much.